pills were. I was not set up for a good placebo response. I just thought he was a really nice man who was interested in me, but I didn't have any faith in those little white pills. Well, over the next 2 weeks, I started to get more and more calm. I stopped crying, I was able to sleep at night, and my whole life turned around. Being a child of a psychologist, I was pretty impressed with what had happened. My father was a psychologist in the 50s, and he called the medications that were coming out in those days chemical straitjackets. He was not happy with them. Anyway, I resolved to learn about homeopathy, and I had the opportunity. The universe really handed it to me on a silver platter. When I came back, he offered me a part-time job and said, but if you work for me, you have to come to my class in homeopathy. And that's how it all began for me. Now, I'm going to assume here that everybody has experienced grief at one time or another in their life, maybe many, many times. And I'm going to ask how many of you would have thought to turn to look for a homeopath to deal with your grief? A couple people. Yay! All right. Well, homeopathy is very effective at working on an energetic level with people with emotional problems. And in fact, even on a physical level, I can't treat somebody who has a flu unless I understand what emotional state either preceded the flu or came along with the flu, because we have so many possible remedies for the flu. There are good homeopathic studies that have been done scientifically, but it's very difficult because everybody is individual, and we recognize that. And in looking at a person, we look at the whole person, and we look at every symptom and every condition that they've gone through in their life when we do what we call a constitutional prescription in order to find the right remedy. I have a computer with over 1 million symptoms in it and all the remedies known to cure each individual symptom. And we do a lot of research and a lot of cross-referencing. Now, we have a concept in homeopathy. We believe that every one of us has a vital force. It's the healing energy, the rebalancing energy, the self-regulating energy within us. We all know that we heal ourselves. We have a stomach ache at night, and we wake up and we're better. Or we have a headache, we wake up and we're better. So the body does know how to balance itself. Vital force includes the emotional state as well. So we're really looking at how to stimulate that vital force into action in the body, mind, spirit of the individual. And we do it in a very unique way. Our remedies are really based in physics. They're vibrational. We have a special process whereby we can extract the energetic frequency of a substance into water. So we're really looking for something that's going to trick the vital force into rebalancing itself. And how do we do that? We look for a substance that's been known to actually create the same combination of symptoms in a so-called healthy person as the individual we're working with. I'm going to give you a super, super easy example that's just to give you a sense of it. If someone came in with a blistery, itchy eruption that was better with hot water, which is kind of contrary to what you think about itching, and was restless at night and felt a lot of anxiety, we would give them possibly the frequency of poison ivy. Because poison ivy would create those symptoms. In fact, we have about 20 pages of information on homeopathic poison ivy, but I'm just trying to give you a simplistic way of looking at this. When the frequency is given to the person, the vital force responds to this new frequency coming in. And in responding to that frequency, it actually responds to the condition that we're wanting to treat and brings about a healing. Now, Samuel Hahnemann was the founder of homeopathy, and this was back in the late 1700s. And he was actually the first person in the Western world that we know of to advocate compassionate and kind treatment of mental illness. These were the days when they would chain people in the asylums and they would beat them And he said, no, this is not the way to treat people. And he really understood the mind-body connection. And there's a lot of information on the work that he did. Afterwards, in the 1847, actually, homeopathy was very popular in the 1800s, both in Europe and in the US. And there were 20 homeopathic medical schools at that time, and 100 homeopathic hospitals at that time. Flower Fifth Avenue in New York was one of them. Hahnemann Hospital in Philadelphia was another one. There were many. Anyway, in 1847, a hospital was established in Middletown, New York, and it was the first homeopathic mental hospital in the United States. And their results were so spectacular that they grew from 69 patients to 3,300 patients that they were treating at any one time. So we have a rich history which has been buried because homeopathic medicines are not patentable. You can't make money on them. And so homeopathy continued. They closed their doors in 1960 when the drug companies became more popular. And actually, the reason why the AMA was founded was to get rid of homeopaths, women, and blacks in medicine, because they wanted to be able to patent medicines. Okay, so what are some of the things that we actually can treat in homeopathy? And I do want to say that we can be very helpful in helping people come off of their medications, both with adjunctive therapy for the condition that they're in, but also there are times when we can actually potentize, make a homeopathic remedy out of the medication and give it to them simultaneously as they're starting to taper off their drugs. I did treat a young man. I have a private practice and I work at Choices Integrated Medicals. You may know of it. But anyway, I work with Dr. Michaels. And a patient came to us. He was 19 years old. He had gone down to Mexico. He took some drug off the streets and he had a psychotic break. He was sent to the hospital up in Flagstaff, the mental hospital, that put him on 3 medications that caused serious side effects and were not helping him. He came into the clinic and he was literally like that with his mother. I wish I'd had a video that day. I chose a homeopathic remedy for him after speaking with him for some time, and within 10 minutes, he became completely calm. So I can't say that happens all the time, every time. It's a challenge to find the right remedy, but that was one obvious example. Another man I treated had voices, was dealing with voices, and they were arguing back and forth. There was a negative voice telling him to kill people. There was another voice telling him not to. There is a homeopathic remedy that's described as having an angel on one side and a devil on the other, arguing. I gave him that remedy and his voices stopped and he was able to continue therapy and move forward in his life. So I just want to say that there are a lot of ways, as you'll hear, of treating mental illness here. I did develop an interesting technique of helping people find their core issue that affects their whole life and actually being able to imprint water with the frequency of that core issue, a la Dr. Emoto, some of you are familiar with him, and turning that water into their own personalized homeopathic remedy. I have a few books here that describe that. It's something a little on the leading edge of homeopathy, but please feel free to ask me questions or approach me later, because this is a very truncated approach to
No.
Suzanne, you have held numerous trauma relief trainings around the world, helping people of all ages healing from devastating events. How long do you typically work with these individuals and communities before you see results? And please share with us your process that you take these communities through.
Okay, well, since you asked that question, I'll just kind of dive right in with one example. Well, first of all, in my own practice, I take insurance often, to help people who otherwise might not be able to afford it. So I do have to make diagnoses. But my marriage and family therapist guru, when I was studying for my license in marriage and family therapy, taught me just almost always just to make one diagnosis: adjustment disorder with anxiety. So almost everybody gets coded that way. But my thought is that most mental health issues are really the results of some kind of a trauma. Sometimes it's actually post-traumatic stress disorder, but often it's a trauma with a small t at some time in their life, often very early on. So that's my real diagnosis. And on my card I have something that says peace in oneself, peace in the world. And I really think that you've probably all heard that saying in some way or another. But to me, most people who come to therapy are not in a state of peace. And I don't mean that everything's going right in the life of that person, but you want to be able to move with grace through the bad times and the good times. And I think that's the job of therapy, is to help people move with grace through the trials and tribulations of life. And I have found a particular therapy that I really have become passionate about. I've been trained in lots of different therapies through the years, and many of them are good, and I'll pull them out of the hat frequently. But one of my favorite therapies is something called thought field therapy. And it's actually a way of thinking about a problem, and while you're thinking about that, you stay in that thought field, so to speak, because a thought is an invisible area of influence, right? And that's what a field is. It's an invisible area of influence. You think about one thing, you feel a certain way. You think about something else, and you feel much differently. And so I have the person think about the negative thing that they want to change. And then it's surprising, and it sounds very Sedona-ish. I find that living in Sedona is a real handicap when I talk about this. But basically, they percuss, vibration, change the vibration, maybe of that thought. No one knows exactly how most therapies work. But in a particular order, they're tapping on their body in a particular sequence. Now, there's a lot of offshoots of thought field therapy or TFT. Some of you may have heard of EFT or TTT, or, there's all kinds of offshoots. But to me, this is the one that's worked best in my experience anyway. And actually, it's now approved by the National Registry of Evidence-Based Therapies as evidence-based. And I'm a scientist, and I'm not really a researcher, but I have gone to the trouble of doing research. And I've done quite a bit of research, and other people have also. And because of that, it's been approved by the National Registry of Evidence-Based Therapies. And there's actually very few alternative kinds of techniques that have gone through that rigorous kind of a study to get that kind of approval. It's not easy. If you went on the website and looked, you would find that yoga and mindfulness, and none of those things have quite yet made the standard. But thought field therapy now has. So, back to that question of, why am I so passionate about this? Because I think trauma is really the root of most people's problems. It's certainly not the root probably of schizophrenia and some other kinds of issues. But most people that come into a therapist's office, especially in private practice, will be, what Bob referred to as the worried well. They've had a loss, life hasn't been fair, they're dealing with depression or some anxiety about something. And I just find that works so well. And as to the question, my average time of seeing people is about 5 sessions. Now, do I have longer? Yeah, I've seen some people for a couple of years, people with, early attachment kinds of issues, people who really need to have more of a sense of self and more of an ego. And, yes, I'll see them for a longer period of time. But I'm really passionate about doing this because I think that if people do have a peaceful heart, you know, not only are they happier people, but people with a peaceful heart are better parents, they're better spouses, they're better members of the community, and they're better members of the global community. So I really think it's important to help people through these traumas in their life. And, you know, when you're passionate about something, you think about it a lot. You spend a lot of your energy on it. And that's something that I've done. And I've traveled around the globe to many different places teaching thought field therapy. Right now there's a group in Israel with Herzog Hospital. And I've trained that group, and they're doing some research with this. I've done quite a bit of work in Rwanda. And interesting about Rwanda, because I started because I was working with Charity Hospital after Hurricane Katrina. And the CEO of Charity Hospital, which was very, very hurt during the hurricane. They were in there for 6 days. They didn't know if they were ever going to get out. They were self-ventilating people. They were carrying people up to the higher floors. It was very, very difficult for them. And so they wanted us to treat the staff. So we were there and we treated the staff and the doctors, even the policemen, because Charity Hospital doesn't just have security guards, they have policemen because it's a place where low-income people are coming from the prisons, so forth. It's America's oldest charity hospital. So while I was there, part of our team was a man who was a Lutheran minister, Paul Oss, and he was going to be going to Rwanda to a center for street children. And so he asked me if I would go with, and quite a few of us volunteered to go. And this was just a little center, you know, it didn't have windows, but it was a shelter for street children since it's become, you know, a much safer place for these boys. But at that time, we did some simple tests. There were 400 kids there, and they all got treated. And we tried to do this random controlled study, and we were still kind of naive. That was my first study I was ever involved with. So we had 3 groups, and we picked only the boys that were old enough to have lived through the genocide, because we had come several years later. So we did the assessments, both the parent assessment, which they didn't have parents, but the caretakers did the assessments, and then the children did their own assessment. And then we treated some with the thought field therapy, and we treated some with relaxation techniques, and another one with the deep breathing technique. But the problem is that kids that got the thought field therapy got so much relief that they started treating the other kids and teaching them how to do it. So that kind of messed up. So that was not a random controlled study. But since then, you know, I've been back many times, and we had a women's group who work with trauma, just lay people. And what I decided is that what we really need to do is not go there and treat people. We need to teach community leaders to treat people. And that's really in keeping with the World Health Organization's recommendations, because at any one time now there's about 780 million people suffering from mental illness in the world. And we're underserved here in the United States, and you can't imagine places like Rwanda and other places how underserved they are. So the idea is to treat community leaders, and then they can treat others. So we did some research there, and that truly was a random controlled study. And most of the people met the criteria for PTSD on the trauma symptom inventory. And what we did is we randomized the groups. There was about 150 people, and half of them got treated after their testing by the newly trained therapists. They took a 2-day training, and then they treated half of the people. And then 1 week later, because our time was limited, the whole group, both groups took the test. And there was a dramatic difference between the group that was treated and the group that was not treated. It was 0.001 difference on almost all the scales of the trauma symptom inventory, plus some other inventories that we did. And 2 years later, when we went back, the results were even just a little bit better. Not significantly better, but a little bit better. They held for 2 years. And then a priest had been calling me, and he wanted to have people treated too, and he wanted to learn how to do this. So we arranged another trip to Rwanda, and then we did exactly the same thing, tried to replicate exactly the same thing. And basically, the results were the same. He had 200 people. He was an amazing organizer. 200 people came, and 198 people finished. One person had died, but everybody, almost everybody finished. And we did exactly the same thing. You know, the newly trained therapist had one session with the people, and then there was a test to compare the treatment group and the non-treatment group. And anyway, the answer to that question is the average treatment was 55 minutes by a newly trained Rwandan therapist, and yet the treatment held up over a year later. And that didn't cure all their problems. You know, they did much better on these inventories, but the thing is that there were people in place, and they could come with other problems that came up. And so now the people that we've trained, I've trained about 200 people in Rwanda, and some of those people have trained many other people. But just those that we can track from those 200 people, 400,000 people have been treated. And so a movie was made on this, and people gave testimonies. And some of the most dramatic testimonies were things like, a woman would say, you know, my housekeeper killed my father. And he was in prison, of course, at that time. But then you hear her later in the story say, and when he was let out of prison, I forgave him. And now he walks me home from work every night to make sure I get home safe. And story after story. And I don't believe there was any placebo effect. People thought we were crazy. The translators thought, what have we gotten into? In the film, people say that over and over. One woman said, they asked me to talk about my problem. I have a machete mark in my skull. I was buried alive. What kind of people are these? You know, this might work for Westerners, but it wouldn't work for us. She said, they said they came because they thought took it as an opportunity to hang out. And she said, we thought they were more evil than Satan. So I don't really think there was much of a placebo effect. And I see this all the time. You know, I see people come in, and it doesn't work for everybody. But, you know, so often people come in, and it's like, they say, what happened? How did you do that? And how often in a therapy session, you know, before anyway, in my experience, did people just look at me and say, what happened? What did you do? And the next time they'll come in and they'll say, my whole life has changed. And of course they often have other things to work on. And I don't know exactly how it works. You know, my guess is that you're taking the sympathetic nervous system response, that fight or flight response, and they're thinking about it. They have to think about it or it won't work. If I was doing acupuncture, which it kind of is, we're using the acupuncture points. It's not acupuncture, but we're using those points. A person wouldn't have to think about anything. But obviously the thought has to be there in order to change that thought or that feeling or that emotion. So that's what we're working on. So that has to be there. And when they're finished, it's like, oh, you know, where is it? I can't find it. It seems so far away. And it's not that they don't remember what happened, because trauma is often what we're addressing, but they just feel much differently about it, like it's stored in their long-term memory and it's long ago. So, you know, as much as possible, I try to spread this as much as possible. I try to give classes in it. I've taught people at one of the veterans hospitals. And the interesting thing is they're getting good results, but you can't document it because it hasn't been approved. Even with our evidence base, they still haven't approved it. But we do have a study that's going to be taking place in Las Vegas, Nevada, in the veteran community there, so outside of the VA. So we're hoping that maybe that'll help us get into the VA. So, okay.
Thank you, Suzanne. Jeff, you've been researching and practicing somatic therapies for over 30 years. Please share exactly what somatic therapy is and how you have integrated this in your practice.
Thank you. Well, first of all, I wanted to thank the Mental Health Coalition, Barbara Luttrell, Dr. Grace, Rob, Kermit, all of you. I have to say, honestly, I'm humbled to even be invited and sitting in the room with all of you change agents, and to just share a little bit about my practice and what I do. Somatic therapy, I'm pretty sure most of you can probably teach me what somatic therapy is, based on your education. So I'm sort of speaking to the masters in the room. But in its essence, somatic therapy is basically using the mind-body connection to activate or engage and downregulate the autonomic nervous system, the sympathetic dominant or sympathetic activation of the fight or flight, and bring it into a more manageable or de-escalated state. So we're taking the individual from an awareness of the fact that they're even in an escalated state to an internally de-escalated state, which they then can translate to an externally de-escalated situation. And I say it in this way because I've dealt mostly in the recent time in an acute situation with law enforcement and fire and EMS individuals who are suffering from post-traumatic stress symptomatology. My history, just to put you all to sleep. My background, because I'm a big why guy, and why would you want to sit here and hear what I have to say? I started in mind-body therapies at a very young age. 10 years old, I was apprenticed to a therapist in my community because of an interest in traditional Chinese medicine. And I was very fortunate that this young woman agreed to teach me all she knew, and she did, along with 2 other mentors that I had at that time. And so I learned massage therapy and a little bit about traditional Chinese medicine and some energy medicine to tag all those woo-woo people in the room because we're near Sedona. And from there, at 16, I graduated high school a year and a half early and moved to San Jose, California to work with a gentleman named Marcel Vogel, who had a research laboratory in San Jose. And Marcel was actually doing thought field work on the structuring of fluids, including water and wine, and he was actually going to move into bodily fluids 20 years before we'd ever heard about Emoto. One of my goals, one of my missions, is to honor my teachers, and Marcel, unfortunately, was a man way before his time. And I honor him with being the nexus point of my sort of understanding and taking that teaching that I had forward into really sort of pinpointing my understanding that the experiences of our lives are written into the tissues of our body. We can very easily get lost in this command or control center, really the driver's seat behind our eyes. And as mental health professionals, it's probably very easy to get locked in the mind or the thoughts, as opposed to the interoceptive awareness of the body and its impact on that mechanism. But literally, your mind is not behind your eyes. Your mind is everywhere. And as I've been doing yoga long before I was doing body work. We would say that your mind actually extends beyond your eyes and beyond your body and beyond the confines of what it is that we see in the material world into all things. And in fact, this patient that you're speaking to across the table from you is actually you. So you're diagnosing yourself, which is an interesting concept in yoga. But from that, and from my experience in my own practice, I started to see individuals that would come into the work, and impressions would arise during our sessions of experiences that they would have 20, 30, 40 years before that, of course, they weren't thinking about. That wasn't in the forefront of their mind. But that experience had somehow locked itself into the location that we were addressing via that session. And that really got me thinking into how is this even possible? Yeah, I know that issues are in our tissues, or our world, our experience is written into the tissues of our body, but how? How does that actually happen? What's the mechanism behind it? And so for the last 5 years, that's been my passion and my study, the actual mechanism behind the encoding of these issues into our tissues. And one of the things that struck me here, and I'm putting this out because you all are amazing researchers, and the fact that you're here shows that you have an open mind to a lot of this information, is what's the actual chemistry behind the release of this information out of these tissue structures, and how do these hormones, these chemicals that are being prescribed, how can they either facilitate or impede the release of that information from the tissues? How do steroidal chemicals facilitate or impede the release of photonic or protonic information from the molecular structure of our tissues? Do they? Anybody out there have a connection to a university or research laboratory? I'd really love to talk to you after this. So short answer, somatic therapy connects the mind and body and downregulates the nervous system. Yes, ma'am.
How have you integrated it into your practice and what you're doing with first responders? I think is
Right.
phenomenal.
So how I came to work with first responders is very similar to the way that I came to work here. It's kind of by mistake or by serendipitous accident. I was teaching a course on this encoding of the issues into the tissues, and the director of Yoga for First Responders saw the presentation and said, I've got to have you as an instructor, and she literally basically made me the assistant director of the program. And what's beautiful about that program is that we literally go into the firehouse, we go into the police department, we go into the academy environment, and we connect with these first responders, and number one, we educate them as to what it is that they're experiencing, because they're experiencing more trauma in one episode or encounter than most of us, present company at least, for myself, have experienced in our entire lives. In one encounter. And then they'll have to go and do another encounter. And their nervous system may not be de-escalated at that point. So there's this recapitulating and piling over and over and over on this nervous system, and it blows out, the HPA axis, the sympathetic nervous system, so it can't shut off. And so when we have the opportunity to stand in front of them and take them through a practical exercise where they feel it embodied as opposed to think it, oh yeah, I'm relaxed, but they feel it in their body, it tends to impact them pretty profoundly. And then for us to be able to take the practice of yoga, literally, when you hear that, you think bendy postures where you take your right foot, bring it around the back of your head, and stick your big toe in your left ear. That's not what we're talking about. When we talk about yoga, we talk about the full practice where, number one, it's cultivating a specific quality of mind through observation, self-restraint, cultivation of specific attitudes. And then you move into physical postures which engage the tissues and allow for these impressions to start to arise into the nervous system. And then you move into the breath work. But breath work actually helps us, number one, to harness that information in the tissues and facilitate its movement through the neurocognitive apparatus. And then we take their awareness inward. So this is very externalizing. I mean, they can be joking in the firehouse or the police department, but then when you start taking them inward or involuting their awareness, bringing it to the interoceptive space, we start taking them down into those deep brain structures where they start to see the truth of the experience as opposed to the story that the neocortex has made up about it, right? That they've had to make up about it. And it's not this extremely cathartic experience. It's a very subtle and gentle unfolding or unwrapping of these traumas that starts to rise up in their subconscious, in their dream state. And we're there consistently over a long period of time. So there is a level of sort of trust that's built, and there is a level of reapplication of the process. And then from there, if they continue or they want to, we facilitate the training of these individuals so that they can heal the healers, and introduce it into the academies. Our main goal, and I'm speaking for Yoga for First Responders here, is to have the opportunity to move into the academy space so that we can create something called not only physical resiliency, but mental resiliency and neurocognitive resiliency before they go out into the field and have those encounters. That they're ready to go, that we can actually strengthen the brain and the nervous system as well as the cognitive apparatus before they even have that experience. And pass that on to their partners in the field. So that is, in another nutshell, the mission of Yoga First Runners and how I've incorporated that into the practice. So thank you so much again for the opportunity.
And last but not least, we have Kermit. And please share with us about open dialogue therapy. And I know you have a little presentation, or you're gonna you're just gonna speak.
I'm going to try to do this standing up.
Good.
I'm going to try to do this standing up. First, that was beautiful, your work with first responders. I really admire that. It's very beautiful. So there was mention that there's been a lot of scare talk today. And it's true that a lot of what we've talked about is scary. So I'd like to focus on the... Okay. So it was mentioned that there was a lot of scary things talked about today, and that's true. So I'd like to focus on the good news. And if I do what I'm hoping, you'll leave feeling quite empowered and quite hopeful about what you're able to do. So, and just like to track back to one thing, it's on my mind, the study, the Rosenhan study, the study where they sent people to hospitals pretending to have illnesses. There was a follow-up to that because one of the hospitals said, please send us your researchers again and we'll detect them. Rosenhan sent them, or no, what Rosenhan did was he said, yeah, I'll do that. And he didn't send any. And after the hospital had seen 193 people, they reported that 41 of them were faking. So the good news is that 21% of the people in that time period who would have been diagnosed weren't. Which tells you a little bit something about diagnosis. So I'd like to go back to this question of the presentation of the idea that there's a 1% consistent rate of schizophrenia diagnosis around the world. Let's assume for a moment that that is true, that 1% of the people in the world meet criteria for a schizophrenia diagnosis at any given time. The question is, what does that mean? What does a schizophrenia diagnosis mean? It means that you exhibit a certain number of a certain set of behaviors. You might talk too much, you might not talk at all. You might, any number of things. Any two people might not have any symptoms in common. There is no test for this other than the behaviors. So what some people think a schizophrenia diagnosis means is that somebody is speaking or behaving in a way that we don't understand, and it frightens us. And we don't know what to do about it, so we call it an illness, and we have a hypothesis that at some point in the future we will know what the biochemical basis of this is, and meanwhile we're going to do whatever we think will help that, or seems to help it. I have worked in schizophrenia research alongside some of the biggest names. I know that behind closed doors they will tell you that we don't know anything about it. They will tell you that they, in their own research, did studies and wrote papers that contradicted the dominant narrative of schizophrenia. They, the biggest names in research in schizophrenia, could not get those published because you can't get something published that runs against the dominant narrative, as has been mentioned. So what does it mean to not be able to publish something against the dominant narrative? It means that your perspective, what you see as being true, what you feel and know as being real, is not being heard and is not being included. in the narrative that is shaping the life in the world that you live in. Doesn't that feel distressing? That's why a lot of us are here. We're here because we think we know something that isn't embraced, and it's scary, and we've seen terrible things. We've seen people that we love treated in ways that didn't help them and hurt them. And that's why we're here. My journey, I saw that growing up. I saw people labeled, diagnosed, treated in ways that didn't help and did hurt. And I went into film. I didn't know how to. I didn't have a basis to question any of that. I didn't think it was. It didn't seem right to me. So I didn't know what to do about it. So I went into the film business because I thought maybe I can create stories that will change the world. And I had a little bit of success. But when I got to where I thought I wanted to be, it wasn't satisfying in the way that I thought it would be. And when I looked deeply at what I was doing that was satisfying, I realized I could just, rather than sit with actors who, I'd rather be with people who admit they're crazy. I loved the work. I loved the actors. But I realized, because I started doing this kind of grassroots peer counseling thing, I realized I got all that I wanted out of doing that. Working with people in crisis. And the deeper I went, the more satisfying it was, and the less I wanted to film it. The less I could imagine filming it and selling it to Rupert Murdoch. And I realized at a certain level of working with people in crisis, you cannot film it. You have to be there, and your loyalty has to be in that moment only. You can't think about bringing back souvenirs. You have to be there. And I found that very satisfying. So I left film and studied psychology and went to work. And in the course of it, started working with more and more crisis, people in severe trauma, and eventually working in schizophrenia research. I found I liked people. The people who were researching, I liked them, and they were all traumatized. So I was thinking something is not adding up, and I read Bob's book. And because of that, largely because of that book, I went to work in a residential treatment. And I found by working with the space between people, we could get everything done that I wanted to do. I'd sometimes say to people, if you go to your therapist, they say there's something wrong with you, but if we fix it, maybe you'll get to have relationships. And I would say to people, well, that's all fine. But here, we're having relationships, so maybe you're okay. Let's start with that. And whatever's coming up, we'll deal with that. So another piece of the good news I wanted to say, the question came up earlier, is it okay? It said that 1 in 5 people will face a crisis, mental health crisis in a year. Is that okay? The good news for me is, yes, that's okay. Because that's what life is. Life is dealing with pain and fear and suffering and the unknown. And how do we face pain and fear and suffering and the unknown? Together. We figure it out. That's how you do it. That's how we've always done it. But in recent years, we've had this enormous industry arise that tells us, you don't have to do that. You don't have to have pain and fear and suffering. Take this, and then we'll have a relationship and we can talk. Everything can be fine. It was said, I think, think of the name of the movie later, but the statement was, anybody who's trying to tell you that, I'm paraphrasing, you can eliminate pain and fear and suffering is trying to sell you something. There's now this enormous industry that's not just trying to sell us something, it's actually deep into our court system, deep into our government, deep into, telling us who we are and what we can be and how we should do it. And that is scary. Okay, so I was to talk about open dialogue. That's the good news. So let's look at where the good news is. In this area of Finland, right up just below the Arctic Circle, tucked away out of view. For 35 years ago, they had the highest rate of schizophrenia diagnosis in Europe, if not the world, maybe. Europe, anyway. We'll take that. They had hospitals that were overrun, and they got a government directive to reduce the number of people in hospitals all over Finland. In this one catchment area, one of the 6, I think, or 7 catchment areas in Finland, around Tornio, happened to be people who were of a certain disposition. They were disposed to doing family therapy. They had been unsuccessful in eliciting people into family therapy, but they thought, well, if family therapy is what we do in response to crisis, people will do it. And more than that, basically this group of people, they took over the system, or they were the system. They transformed their system over 35 years to make family therapy, and more than family therapy, systemic treatment of family, the network of friends, work, school, whatever was the meaningful network of relationships that a person has. That is the response that they had to any mental health crisis that comes in. So a person picks up a phone, calls, says, we have a mental health crisis, whatever they say. Somebody's crazy, whatever they say. The first thing that happens is a team of people from the community, the city, comes to the house, and they sit with them, and they get the network together, and they say, let's talk. Let's figure out what is the narrative here. I'm paraphrasing, but let's all talk. And what they have cultivated is a response that doesn't come from the DSM. They don't do diagnosis. They say, we don't need diagnosis to respond to a crisis. We don't need diagnosis to know what a human being needs. They just go and they sit with them. They sit for as long as it takes. They come back the next day or the next week, for 20 years, whatever it takes. And they do not assume that the problem that was phoned in exists within any person. The assumption is there's a problem in this network of people. Let's find out what we can do. And they sit with the people and they say, we don't come in here with knowledge that's going to fix this. You people know what you need. We're going to figure it out together. And this is what I've said years ago, before I really even knew about Open Dialogue. I would say to clients, I have book learning, I have theories, we can talk about them, but I don't know anything, and I certainly don't know anything about you in this room that we don't figure out. So for me, a long time ago, it started with saying, nothing outside of this room matters. It starts here. Everything we need to know is in this room, and we will figure it out together. And I've done this with people in severe crisis, severe suicidal crisis, severe everything. I've worked with people with serious, full run, schizophrenia, psychosis, people who are very frightening. I have nerve damage. I've been down the road. I would say I've worked with people in as extreme a state as anybody. And as an aside, when I've sometimes confronted certain medical people with research that seemed to contradict, or did contradict, what they were saying, their ultimate fallback was to say, I know my clinical experience. At which point I say, you're not talking research anymore. You're not talking data. You're talking clinical experience, and I will put mine against yours, because I have seen people who were told you have no life to live, you're going to be schizophrenic and on medication the rest of your life. You will be lucky if you work at McDonald's, but that's an aspiration. And I've seen those people, some of them I'm very close to, throw all that away. And within a few years of having negated that, risen to the top of their professions, world accomplishing people. So I don't accept this distinction that there are some people who, it's like, okay, we can deal with all the people who are, worried well, but we'll take care of the sick ones. That's not my experience. And the research, some of the research that Bob presented, I know I'm rambling a little bit, but I'll come back. Some of the research that Bob presented, was that Harrow that was referred to? That the bottom line here is that the initial diagnosis, the initial prognoses for these people, whether it was very, the people who went on the medication did worse. Whether they started off at the worst prognosis or the least bad prognosis, and vice versa. The people who went the medical route did worse, and the people who did not go the medical route, even if they had a very extreme prognosis, very extreme diagnosis, did better if they did not go the medical route. I'm going to use that to tie back to open dialogue. So sometimes I have presented about open dialogue in some certain context, and I get the same response. Well, that's all fine for the less well people, but the really sick people, we will deal with. We'll take care of the really sick ones. Well, in Tornio, what they found is that no matter how severe the diagnosis, it was whether they could get the families talking that made the difference. Whether they could get the person's social network to be one that within this person felt safe, that made the difference. And whether, no matter what the initial severity was, it was whether people could be brought to speaking. So talking about the trauma, you talk about little t trauma. I think some of the research says that actually you can track dissociation, which has always been thought to be a product of traumas, physical traumas. I think there's a problem with talking about trauma, which is that as soon as you say the word trauma, people have an image. They look for the image, somebody doing something to somebody, and they get kind of focused on that. But what you see in Tornio is that when you focus on not the trauma, but whether people can communicate. I don't think I just said exactly what I was trying to say. The research says that dissociation goes back not to the trauma, but to the nature of the organization of the family. Could people speak? Could people be understood? Were they heard? Etc. And if they couldn't, they would end up dissociating and diagnosed psychotic. So if we can talk, which we are doing here, we can create mental health. We don't even need to fix the whole world. It starts right here with people that you can talk to in any room that you are. Any person, one-on-one. You can talk. That's where mental health starts.
Thank you, Kermit. We have 10 minutes for Q&A, so.
Hi there, Dr. Pekich. I really appreciated what you had to say. I have been diagnosed with bipolar, and I do take medications, and today was scary for me. It's also hopeful, but it was scary, and I needed to hear. I am actually more functional now since I've been on medication than I've ever been in my whole life. So, thanks.
And I have something to say to you as well, because my mother was schizophrenic, and back then they didn't have the medications they have now, and talking didn't really help. She tried to kill the children and then herself. She's in now the mental hospital, ECTs, lots of things. She wasn't able to be helped. It was scary. And she did end up killing herself when she was going to be committed to the state hospital. And she did in a very gruesome way. But I didn't know her. I only knew her illness. But I also developed a serious mental illness. And I recognized the signs. I got paranoid like she did and stuff. And I went and got help from somebody like you. And I'm so thankful. I've got 2 children. Been married 43 years to a wonderful husband, but I didn't have to stay on the antipsychotic for the rest of my life. I was on it for years and did DBT therapy, and I said, you know what? I think I can think very well for myself. I got out of it. And I lowered dosage of many things. I think I have to do my part. It's a lifestyle choices that I have to do. My doctor wrote on a script, exercise every day for 30 minutes. That's one of your medications. So it's not just popping pills. And I'm thankful to be here because I had my first suicide attempt at 15. And the medications and the doctors, really, that's why I'm here.
For sharing. Anyone over on this side, and there's a hand here.
I wanted to ask Mr. Masters where your practice is, and could you give a more concrete example of your technique in working with someone?
Thank you. I have a practice in Sedona, and I live in Cottonwood, so I have the option of doing practice out of there as well. I have a space. Concrete example, it's going to vary depending on the individual and what exactly is going on. If there's chronic pain, it's a very complementary therapy, so working in conjunction with allopathic or whatever their course of treatment is at the time. So if I can, and it's a possibility, I like to consult or at least speak to their physician so that we can have so they know what I'm doing and I can support the course of treatment. And so it may be purely physical, so that they're starting to get back interoceptive awareness of their body. I mean, this may be somebody who has disassociated from their body because of pain or just not enjoying life, and so just getting them back into their physical tissues and getting a sense of pleasure just from being in body. Or it can go all the way to teaching mindfulness-based practices of meditation in order to harness aberrant thought patterns, or so it varies. Or it could even be soft tissue work, on body, actual soft tissue work to release restricted or impinged nerves. So.
First of all, I'd like to thank Dr. Tetrick for delineating the difference between SMI and the walking wounded. I felt, I guess, a little offended and stigmatized up until you spoke, and part of the problem in dealing with a serious mental illness once you're stabilized is the stigma. But I'd like to also say that in Arizona per capita we have more psychiatrists than most of the rest of the country. However, most of those psychiatrists choose not to work in the public system. So thank you for working in the public system, but the result is that we end up with more nurse practitioners and others that has been specifically stated that we get not the best of care. I think the nurse practitioners do that, but it has been, reference to that group. But what I would like to say, this conference has been wonderful. The last thing that I would like to say is we have what's called first break clinics, and there's one in Tucson and one in Phoenix. I don't know if you guys have them up here, but that is what they do with young people that's had their first break. A lot of it is working with the family. So there's a lot of validity in that. It's just that many of us have gone way past that, and there's some stigma, in the sense that we just don't respond like the walking wounded. So I would like that respected.
Thank you. Thank you for sharing.
Hi, I'm Linda. I am so excited to hear what all of you are doing for alternative modalities of healing. I was diagnosed with bipolar 1 with psychotic issues back in 2005 by my ex-husband, who I had just asked for a divorce, who put me through the system. I was alone. I had zero family support, zero support from friends in Massachusetts, was put in McLean, Emerson, the best psychiatric hospitals, drugged out of my mind, could not function for 10 years. I came here in 2014 to get away from that system. I was followed here by a conservatorship, guardianship, I think under my ex. I'm still working this out. I have been off medication. I have got myself out of the clutches of the system for a year. I'm practicing, learning about minerals in my system, learning about what my way of taking care of my stresses, but I have been through the ringer with trauma, and it still comes up, the anxiety comes up. I have still alone, I have some help, I've had help here now.